Welcome to the Johns Hopkins Women's Health Podcast, A Woman's Journey, Insights That Matter. I'm Kelly Gear-Ripken, and I invite you to listen to Johns Hopkins specialists discuss the latest topics in women's health. Now here's your host, Lily Shockney.
Hi, this is Lily Shockney from A Woman's Journey at Johns Hopkins, and this is our podcast, Insights That Matter. Today we are joined by neurologist Charlene Gimaldi, who is an associate professor of neurology and the medical director of the Johns Hopkins Sleep Disorders Center. Let's discuss the importance of sleep, something that I don't think people really think about very much, and yet it's a very important part of our life, and the impact that a sleepless night can actually have on our health. Recently, I read some staggering statistics that showed that 50 to 70 million people in the United States suffer from one or several sleep disorders. 30% of adults in the U.S. population suffer from insomnia, and 10% are chronic insomnias, making it the most common sleep disorder that there is. 75 to 90% of insomnia sufferers have an increased risk of other medical disorders, such as GSD and pain conditions, as well as hypoxemia. So this is an important subject for us to share with our audience that's listening to us today. What medical conditions have been connected to lack of quality sleep?
That's a great question, Lily. It seems as though the list keeps growing by the day. The immediate medical conditions that we will see is from the standpoint of cognition and thinking. You could see that from the morning after you've had a poor night's sleep. So we know that folks' ability to concentrate, their attention, even their mood is impacted even just after one night of poor sleep. The other thing that is apparent as well is just our reaction time, our ability to respond to things in our environment can change even just after a single night. Why is that important? That's important because we share the road with folks who could very well have had a poor night's sleep, and certainly in areas of the country where people may be on the road for an hour and a half commute to get to their job per day, you could see how this is not just a personal problem, but this is a public health and safety problem. That's short term. Long term, we know that if, just like not paying towards your debt, it can continue to build up. There's long-term ramifications for not getting a good night's sleep. And that is now associated not just with cognitive problems in the immediate, but actual risk for dementia is increased, your risk for diabetes, your risk for stroke, your risk for heart attack, and even your risk for hypertension or the ability for your doctor to control it well with the medications that you're being provided.
Boy, that's really serious because you've just listed a lot of very common chronic disorders that, quite frankly, are life-threatening.
Absolutely.
I think the next time I see somebody in an accident, I'm going to be wondering how much sleep did they get. What actually occurs in our brains while we are sleeping?
That is $1 million question. But, their research is showing that we have a little more insight as to what's going on.
Good.
So it's not just we're out of a conscious state and that's all there is to it. Not so. There's a couple things going on specifically in our brain now that we've recognized that while we're sleeping, it appears that our brain is actually doing some purging of toxins that naturally build up during the day while we're awake and thinking and doing what the brain is trying to do, which is to be the composer of our entire system. So there are buildup, there are metabolites, there are toxins that are produced as a result of that during the day. And when we sleep, our brain is actually working to purge those toxins. So if we don't sleep, those toxins will build up. And why that's an issue is these same toxins are the toxins that we look at that are associated with things like Alzheimer's. Mm-hmm. So these are the plaques, the tangles are associated. There's a link with the toxins that I'm talking about on a night-to-night basis and these kind of biomarkers like plaques and tangles that are associated with Alzheimer's. Wow. So that has been a very powerful finding. There's more work that's being done to look at the connection from that standpoint with our brain. But we also know in our brain, another thing that's done while we're sleeping, or the brain at least is a composer for this, is that we naturally have a drop in our blood pressure while we're sleeping. It's called the natural blood pressure dip. If we do not get the adequate amount of quality and quantity sleep, our body does not do that natural blood pressure dip. And it's believed that if you don't go through that natural cycle of having that blood pressure dip, you're more likely to not be able to manage your blood pressure during the day. So that could be the link between the importance between sleeping and hypertension.
My goodness. How many hours of sleep do we need?
Another great question. So if you go on, let's say Google, Dr. Google, it tells you in general an adult needs about 7 to 9 hours typically. However, I always tell patients that you shouldn't just use that script and say that that's what applies to me. You need to use that as just a general guideline, then to figure out what you personally need, because it may be 7.2, it may be 9.5. It could be within that range or slightly outside. The important thing to do is an experiment on yourself. And how you do the experiment on yourself is to say, I'm going to go to sleep. I want to go to sleep within a time frame that I can fall asleep within 30 minutes. It usually takes most folks about that time to transition. Then go ahead and sleep as long as you need, and you should be able to wake up without an alarm clock. If you can wake up without an alarm clock and essentially feel alert and restored and functioning pretty well during the day, that's how you know how much time you need.
I see. That makes a lot of sense. What are some of the reasons why women don't get a good night's sleep?
As we get more and more into an era where women are the ultimate caretaker for their families, for their kids, for their adult kids, for their adult parents, you can imagine there's so much, the sandwich generation, there's so much to juggle, caring for themselves, that caring for everybody else, what falls on the wayside is potentially caring for themselves. And with that comes prioritizing sleep for themselves. Women often suffer from sleep disorders. Sleep is a very complex thing where there's a genetic component of some folks are just more wired to have sleep problems, but there are also hormonal, depending on where a woman is in their peri, post, or premenopausal, that can affect it. And then, of course, there are cultural reasons and stressors and that sort of thing. So it gets very complex. That's where it's important to talk to a provider, whether it's a sleep expert or someone else, because the reason a woman or any individual has a sleep disorder, it can be very unique to them, and you have to tease those things out.
Yeah, I think that we're so busy trying to do everything that you just described that women do. And then when it comes to nightfall and you've got to throw in one more load of laundry and empty the dishwasher and fix sandwiches for the kids to take to school the next day, that you don't unwind. You just go from that chaos, which may be normal, but it still is chaos, to kind of falling in the bed. And then you start thinking about tomorrow. I've got to do this, I've got to do that. Oh my heavens, I'm worried about my mother's health. Oh my goodness, I'm worried that Johnny didn't do very well on his history test. And the ability to switch gears, if you will, so that you can begin to get rest.
Yes.
I am guilty of it myself. I always try to, a half hour before I tell myself I am going to go to bed, try to start that disconnecting, including from technology, which my phone isn't even in the bedroom. The phone stays in my purse in another room in the kitchen so that I'm not tempted.
You are on the money. That's exactly what's happening.
Yeah.
And that you're right. You have all the chaos of what's going on, everything, and then you get in bed and then you're alone with your thoughts to go through that list in your head.
And isn't it interesting, nighttime seems to magnify the problems. When you think about the same problem in the daytime, it's like, well, this isn't as bad as I thought it was.
Right. Yeah, exactly.
At
like
2
it was
a.m.
last
it
night.
really seemed bad.
Exactly.
But now it doesn't seem quite as bad. Still got to deal with it, but it's not the end of the world as I thought it was at 2 a.m.
I hear that all too often with my patients, and it's really insightful for them because you say, you know what, that problem at 2 a.m. is going to be there tomorrow at 9 a.m.
Right.
So why don't we take a vacation from that.
Yeah.
It's amazing. And I think it's because you're alone with your thought, if you're coordinating and orchestrating for everyone else, you're finally alone with your thoughts and like, but that's part of the process of like helping folks to be the best sleeper they can be.
Yeah.
I get it. Absolutely. This is your time. This
Right.
is your time to decompress and purge. So you can allow your brain to purge.
So what does our circadian rhythm have to do with our sleep?
Circadian rhythm is now the other third extremely important element that we recognize to be the best sleeper you can be. Everybody's pretty aware that you need the right quantity, right? So that's the 7 to 9 hours plus or minus. You have to figure that out for yourself. So it's a quantity issue. It's a quality issue. So I'm sure at some point we'll talk about making sure the quality of your sleep is good, that you're not having things like sleep apnea, and we'll get to that. But also the third one now is circadian rhythm. That's the window. So you're sleeping in the window of time that is most appropriate for what you and your brain wants to sleep. So that's your biorhythm, your circadian rhythm, your window for which it wants to do it. So it's quality, it's quantity, and the window is the perfect window for you. We have a clock, an internal clock, a biorhythm clock for every cell in our body. It's not just sleep, it's for everything. So every cell in our body has a biological clock. The area of the brain that runs all of that, called the suprachiasmatic nucleus, is also in charge of your clock for sleeping. And most folks, that major clock, the master clock, has us ideally wanting to sleep between 11 p.m. and 7 a.m. And I'm talking about adults here.
Yes.
Most folks, that's the period. However, some folks, their circadian rhythm may be delayed. So they may be more of a 2 to, let's say, 9 a.m. or whatever, 3 a.m. You often see that with adolescents who like to roam. Actually, we recognize it's a natural part of puberty and a natural part of brain development that you delay a little bit. And then with age, sometimes you'll shift earlier. And some folks will shift so earlier. That's what we call the morning lark circadian. They may want to go to bed at 9 p.m. and wake up at 5 a.m. And so we do get individuals who worry and get stressed out if they're shifted too much more than maybe members of their family or things like that, because that can impact social activities and such. So this is where we're realizing family time. If they're a morning lark, because they can't stay up for dinner and things like that, and it can affect those who are night owls because they can't get up in the morning for work, for school, for things like that. So this is how we're really starting to understand the critical element of circadian in your biorhythms and being the best sleeper you can be.
Boy, oh boy. Can we talk a little bit more about insomnia? Can you actually define it for us?
As you mentioned, Lily, there are about 30% of individuals at any one time who will endorse some type of a insomnia complaint. But if you go by the book in terms of it being a disorder, it's about 10%. I'll sort of define what a disorder is and when we start to think about formal treatment and such. This is usually a situation where for at least 3 months, a person has had difficulty either initiating and or maintaining sleep, and they wake up and they don't feel restored from their sleep, and it's associated with what they can see as a functional complaint during the day. So they say that because of my sleep, now I am not functioning as well at work.
Can't think clearly.
I can't think clearly. I'm more cranky with my family, and I can directly correlate it with my sleep. That is a big thing that our field has made a point of, is that a bad night sleeping every now and then is not necessarily a diagnosis, and you don't necessarily need to be putting people on sleep aids. It's somebody who says, this is happening chronically, and it's causing devastating daytime impairment for me.
This certainly can impact, as you mentioned about work. I think about people that work in an environment like a hospital where they may be working different shifts.
Yes.
They may be on day shift for 3 days and then night shift for 3 days. So when they're sleeping is going to be quite different.
Yes, and you nicely helped me to loop back how insomnia and the circadian rhythm disorder are tied in there, because shift work disorder is actually another one of the circadian rhythm disorders. Because again, somebody who has to do a rotating shift, they may need to or are compelled to sleep outside of a window that they would have routinely done because they're working a shift.
Yes.
And that usually can cause problems, obviously, with insomnia, because their body doesn't really want to sleep during this time, but they feel they have to because they have to stay awake for their overnight shift, their graveyard shift. So this can cause some havoc. Now we're seeing some health potential ramifications of that. There's higher risk for some folks who've had long-term rotating shift for cancer is higher. That's been shown in men with prostate cancer and women with breast cancer.
Right.
So we're keeping a close eye on that, because there's something that's helping to potentially prevent, and could be a way to think about, from whether it's melatonin or other things that are helping to reduce the likelihood of cancer, and that's unleashed if somebody is constantly doing these rotating shifts. So all of this is really cutting edge research that's being looked at now.
Let's talk a little bit about sleep apnea. I know that there's 25 million adults who suffer from some form of obstructive sleep apnea. 4 to 9% of middle-aged men and 2 to 4% of women suffer from sleep apnea. 24 to 31% of men and 9 to 21% of women actually have obstructive sleep apnea, which sounds serious to me. An estimated 10 million people in the U.S. remain undiagnosed, which is probably one of the scariest part of this discussion that we're going to have. And over 50% of diagnosed sleep apnea cases are reported in people age 40 and over. What exactly is sleep apnea? Let's talk about the central sleep apnea, but also obstructive sleep apnea.
This is a very important topic. Sleep apnea, very simply, is apnea means, it's a Latin word for you're not moving air, you're not breathing, and it's happening while you sleep. And when you add the precursor of obstructive, the reason that you're not moving air, not breathing, is because there's a blockage in the airway. So the back of your throat is closing off intermittently, and that's why you are having these apneic events. Central sleep apnea is when you're not moving air because your brain isn't sending the signal to breathe.
That's trouble.
Okay. And so either one of these is not good. And some people can have a combination of the two. In the case of central sleep apnea, you'll see it with certain neurological diseases. Of course, somebody may have had a stroke that was in the location where your breathing center that regulates breathing is affected. They can have a central sleep apnea. You can also see it in individuals who have medications that affect the brain processing. So even common medications, opiates, that can be associated with, because again, it's dampening down the whole system, even your breathing regulation. But even other medications that people may be familiar with, the benzodiazepines, the Valiums, the Xanax, those can also be associated with potential central sleep apnea. So both of these are very common. The context for which it can occur are very common. Folks should certainly be aware of it. Thank you so much for providing the stats in terms of who is typically affected. I know that often sleep apnea is kind of viewed as more of a man's problem, but
he's snoring again.
Exactly, he's snoring again. And that is certainly the case. But I think I want to take this opportunity, especially in the form of a woman's journey, to make the audience aware that we are understanding more about how sleep apnea in women presents differently. And for that reason, some of those statistics about prevalence may be more due to the fact that these symptoms were under-recognized. And I think it's very important that we all become aware of that.
So what are some of those stand out that are different than what we see in men?
So there's a couple of things, and then also talk about the potential just social aspects of this too. We know with men, they're more likely to be loud snorers. They're more likely to have the frank apnea, so the person's not moving air. That's something that anybody with a blind eye is more likely to be able to see. Wow, my partner didn't move any air. That's very dramatic. Women who have issues with sleep disorder breathing or sleep apnea, they're more likely to still move air so you can see it, but it's so restricted it impacts their oxygen level. in their blood, and there's no way you could see that with your blind eye. The issue, though, is those two, whether it's the one I talked about with a man who has a loud snore, doesn't move air, or in the case of a woman who's more likely to have what we call a hypopnea, where the breathing becomes so restricted it causes oxygen desaturations. Both of them have the same degree of health ramifications.
Okay.
But one is more obvious. The one
when you can see.
You can see and observe. So it's more likely then that person's going to be encouraged to see a doctor. If it's less dramatic in the case of women, it's likely it can go a lot longer unnoticed, unrecognized, even if the bed partner is trying to be diligent.
So how would you figure it out then that you have this problem?
Great question. So there are a couple things that can be helpful is women with sleep apnea are also more likely to complain of insomnia. Sometimes the insomnia, that difficulty maintaining sleep, was because of the hypopnea. It shouldn't be blown off, I just got a lot of things on my mind, I'm juggling a lot of things, I don't need to talk to my doctor about it. Not so. It could be that this is because of festering apnea. The other thing is women are also more likely to present with morning headaches. So all of a sudden, if you're having a lot of problems with morning headaches, it's not, I'm just stressed out, blah, blah, blah.
It's my allergies.
It's my allergies, it's pollen season. Again, it's worth it to discuss with your health provider.
How well educated are primary care physicians about this, though?
I think it's gotten better. We do have a way to go, but I think it's improved. And really, the onus is on us and as sleep specialists and as the healthcare community that we need to provide the education and the tools to do this. Because the healthcare providers, we know that sleep education, even in medical school, we did a study. Most medical schools are providing 0 to 2 hours of sleep education as part of medical school curriculum.
Gracious.
So how could you expect a primary care to have even the acumen to ask the questions? So that's part of where we're making strides to push for more of that at the medical school level. Now, the primary care providers, APPs, MDs, what have you, providing them the tools who are already available is doing things like we provide some educational apps, quick TED Talk kind of things.
Okay.
We provide that to help with that. And then raising the awareness of the public. Because then, just like my parents, my patients help to keep me honest about, did you hear about, let me look that up. It's the same thing. We're all in this together to educate each other.
There surely are people that have heart attacks, high blood pressure, strokes. And I understand that these things could also be associated with sleep apnea.
That's correct. And even the American Heart Association, I believe, at least for the last 5 to 6 years, has listed sleep apnea as both a primary and secondary stroke risk and something that is really considered now a pretty established thing that really should be discussed with any patient who's had a stroke or anybody who's at a high risk for stroke. That sleep apnea screening for that should be done, at least on a clinical level.
When sleep apnea happens, what's actually happening in our throat?
So what's happening in our throat is, I'll give you this kind of picture. Imagine a straw. When we blow into a straw, it whistles.
Yes.
You hear a whistling sound. The sound of whistling is air trying to go through a tighter space, right? In sleep apnea, let's start with that whistling sound through a tight space. That's snoring. So that's when the back of the throat, whether it's the tonsils, adenoids, the palate, is getting tight. The tongue is bigger. It's closing in on things. Air is trying to squeeze through. All of the tissue starts to vibrate, and that's the whistling sound of snoring, just like blowing through a straw. What happens if I then close off a part of that straw? Nothing's going to move. You don't hear whistling, you hear nothing. No air is moving. That's what's happening in the back of the throat. If I was to constrict both ends of the straw, nothing moves. That's what's happening in apnea. The back of the throat intermittently closes off.
So we hear that snoring, and then we hear nothing, and then we hear like a gasp of air to get the breath in.
Exactly. So we hear the snoring. We hear no movement of air. That's the closing off. And what does our brain do to open things back up again? Because remember, our muscles are all relaxed while we sleep. the brain has to wake us up. So those muscles get tone again, including the muscles of the back of the throat. And so what you then hear is the, that sort of thing, right?
Yes.
The snorting, the startle response. That's the brain
Yes.
saying, "Wait, I'm suffocating, wake up." That's what's happening in the whole process of sleep disorder breathing event.
That's exhausting,
It's
isn't
exhausting. Exhausting. So if somebody has severe sleep apnea, they're doing that 60, 70, 80 times per hour.
Ooh, yikes. That doesn't sound like very restful sleep. So certainly those that snore loudly would be in the patient population we should pay attention to. I suspect also those that are overweight.
Yes, so some of the risk factors certainly is overweight. So BMI is a risk factor. I like to tell folks, though, that that's why we don't completely profile, because there's many people who have a higher BMI who don't have sleep apnea, and many people with a low BMI who do. So that certainly can be a risk factor. Some of just the overall anatomy. So if you tend to just have bigger tonsils, a bigger tongue, again, there's less space at baseline for the air to move. That is going to put you at risk. If you're not getting enough quantity sleep, those muscles are not getting, I don't even have time to get the rest.
Yeah.
That's going to put you at risk. That's something we can control. And then from a woman's standpoint, women's journey, we know that gap that we talk about, how it's more of an issue with men, that gap closes once we hit menopause.
Interesting.
And there is a belief that actually not only does it close, it's probably almost equal. And it's just a matter of doing the research to look at this. But certainly the gap closes. And so that's why it's very critical, especially when you're considering the patient and where they are in terms of a woman, their age, in terms of where they are maybe in their menopausal status. This is critical to consider.
Boy. How is sleep apnea diagnosed?
Now it can be diagnosed in ways that I'm happy to say are more options than we had maybe even 20 years ago. Sleep apnea can be diagnosed in a sleep lab. It can be monitored with looking at many different of the parameters we talked about: brain waves, airflow, oxygen, even things like your heart rhythm, that sort of thing. And
even eye movements, I think,
eye
right?
movements, exactly. Pulse, many different things. And that can be done in a sleep lab, especially for patients you're worried about a lot of things going on and there's some complications. That's still the best option and a great option. There is also, however, the option of a home sleep test, sleep apnea test. And that's a really great option for folks who are otherwise healthy. We're not worried about maybe they had a stroke or they have significant lung disease. We really think that there's a high likelihood, based on what they presented, that they have sleep apnea, and otherwise everything else looks good. A home sleep apnea test is a great option. Those are some of the options that we certainly exercise in our sleep programs here at Hopkins. We go from there. Once you're diagnosed, then you come back. We discuss the severity level, because that gives options for what should be used as treatment, including things as simple as maybe you need a pillow not to sleep on your back because it's worse on your back, maybe an oral or dental appliance, or things like a CPAP, a machine to keep everything open.
Or having the man take his dentures out at night.
Exactly. A man take his... What's wonderful is now we have more options, and that we can tailor and have precision management based on the patient's needs and what their medical picture looks like.
Is there an opportunity here for telemedicine?
Yes. Telemedicine is a wonderful option that we're thrilled to have. It is not just necessarily for sleep apnea, but for many of our other sleep conditions. So, for instance, insomnia, restless leg syndrome, other conditions. Telemedicine is a wonderful option for us because we really want to stay connected with the patient. But a lot of it is related to more discussing what's going on, discussing the plan. You don't necessarily need to come to the clinic to do that. That's something that our center now is able to offer for the appropriate patients. Certainly in terms of when we're looking at follow-up management, it's wonderful to be able to provide. And the other additional thing that it provides for us that we couldn't get in the quote-unquote sterile clinical environment is that we can have a chance to see their sleep environment and what's going on there. And so that can actually add additional gravy and bonus to providing suggestions for them, i.e. like, oh, it looks like you've got a full-on desktop computer right next to your bed.
Yes.
Good. Maybe we kind of want to move that out. Things like that, you'd be surprised. So it really
and
is
you're keeping
wonderful.
the room at 78 degrees.
Exactly. So so it provides that added benefit, and we're thrilled that we're able to potentially offer that for folks if it's an option for them.
That's terrific. So how do you go about treating sleep apnea? And I also do want to talk about restless leg syndrome in a moment too.
So there are many different options for treating sleep apnea. So it usually starts with once you've confirmed the diagnosis, and then you determine what severity level they're at. If it's mild, moderate, or severe, you always have the option of what's called a PAP device, or a positive airway pressure device. And essentially what that device is doing, usually with the interface of a mask connected to your face in some way, it is delivering air at a high enough pressure so that, again, that straw that we talked about, it stays open.
Keeps
and
it
doesn't
open. Yes.
doesn't collapse. So it's just blowing that straw open. That's what the PAP device does. And there's a bunch of different types. They can get fancy in terms of the bells and whistles, but the overall mechanism, that's what it is. Mm-hmm. That's one thing that can be offered at any of those levels. However, there are other options aside from that. There are some individuals who have said, I'm mild. I'm actually in the process of trying to lose weight. This looks like maybe that's a risk factor. And if they're mild and they're really on a course to do that, we actually make that part of the plan. Hey, now we have more motivation to do this. And in that case, we would use that as a treatment plan, have them come back in 6 months or so, repeat it. And if you hit two birds with two stones, good for you.
Yeah.
So that's more of the conservative risk factor reduction kind of thing. Also things like, are you on a medicine, maybe you're on a pain medicine that you're about to wean off, you don't need that anymore. Let's talk to your doctor, let's see if you can get, and then we can revisit. So that's the most conservative, and that's what we do anyway for everybody. What are the things that are contributing? Then in between that are some other interventions. So there is the oral appliance that can usually be done through a dentist. What they do is customize a mouthpiece that helps to keep the airway more open so it doesn't collapse. So it's just pushing the jaw forward like a mouthpiece so that, again, there's more room for air to move and it doesn't collapse. Those are some of the most common and conventional things that we talked about. There are other things that are now been introduced in the last few years, one of which is a device that's implanted in your chest, and it basically controls a nerve. It triggers a nerve that is associated with muscle tone of your tongue. So it's called a hypoglossal nerve stimulator. And it
sounds like the answer to a question on Jeopardy.
Exactly. So this hypoglossal nerve stimulator essentially stimulates the nerves that are in charge of the muscle tone of the tongue. And that's how it increases the tongue muscle tone so that the tongue gets out of the way so that you can breathe. So that's one that's as an option. That's usually an option for folks who have not done well with the more conventional options. But that's something that's like an implantable device, just like a defibrillator, just like a vagal nerve stimulator for seizures, that sort of thing. That's
Does it also help a patient with swallowing? Or no?
You know, that's a good question. Because it's usually turned on just while you're sleeping.
Okay.
That's interesting that they may be looking at that as for folks who have dysphagia during the day.
Stay tuned for info on that.
Stay tuned for that. And I'll say that some other exciting things, it's very much in the preliminary developmental stages, but there are now a few medications, pills that look like they may have some promise as to be in the space to treat sleep apnea. So stay tuned. I think this is very exciting.
That's exciting, yeah.
It's mainly
it's hard to get people to use a CPAP, particularly if they are in a relationship.
Yep.
Because it's like the third person in the bed. And yet it may actually be saving their life. They still have that sense of embarrassment or inconvenience or whatever that might be the driving force for them to say, I don't think I'm going to use that right now.
And Lily, I think you hit the nail on the head too, that may be the other issue that a lot of times women are faced with, oh, this isn't really ladylike, I don't really want this. And I think that can be another hurdle, even more so. I try to approach it this way with my patients. It's not flippant. Like, I understand this is hard to adjust to. I'm on this road with you. And trust me, as soon as we have something better, I'm all over it. And we have evidence to show it. But in the meantime, I can't always say this in medicine, that I actually have something that, although it may be hard to adjust, if you can do it, it works. And we can't always say that. Just try to say we're on this journey with you to get you to that place.
If we can get them to experience it and experience how much better they feel in the morning, then that's a wonderful incentive. But it's taking that first step can be difficult. Let's move on to restless leg syndrome. I have restless leg syndrome. My husband said I pedal a bicycle most of the night, and he can count exactly how many seconds that I will pedal and then stop, and then he says it's 17 seconds, and then I pedal and I stop. We even got a king-size bed, so I would have more room for pedaling, but he says I still wiggle over to his side and kick him away from my bicycle. So
you're doing Tour de France.
I apparently do. Can you first describe it?
Sure. I can. So restless leg syndrome, as Lily pointed out, it usually impacts the legs, but not always. It can sometimes move all the way up to other parts of the body, but it is this sensation that's usually described as an uncomfortable, annoying sensation. Others can say it's full-on painful sensation. It comes on at rest. A movement usually relieves it almost immediately. And it has a circadian component. And that circadian component is it tends to be worse at night. So, i.e., this is how it quickly became part of our sleep armamentarium. Our neurologists who are movement disorder specialists also treat restless leg syndrome as well, because it can also be associated with other neurologic conditions like Parkinson's disease and some neuropathies. But it really became part of our space too because of the fact that it happens worse at night. And the only way to make it better is to walk around and move your legs. So it's not so compatible with great sleep. This is a condition unlike sleep apnea, where it has been well recognized to be more common in women. That increase in the bump of seeing it happens after puberty. So we know children do get restless leg syndrome too, but it's usually boys and girls, it's at equal rates, but it skyrockets after puberty, where it becomes almost sometimes 3-to-1 more common in women.
So what are some of the treatment options that can be considered?
Just like many of our sleep disorders, we'll start with the basics. We'll say, okay, there are some things we know that can actually trigger or exacerbate restless leg syndrome. So let's see, is there anything that we can do to eliminate those before, again, we introduce any medications? Some of these things can be things like one obvious one that, again, so nicotine. If you were smoking, I tell folks there's another reason to quit.
Yes.
There are also certain medications that can trigger restless leg syndrome. You should always be talking to your provider. Do I need to be on these? And revisit that. Sleep deprivation can make RLS worse. So again, striving to get...
That's what I've noticed for myself. I even will tell my husband, tonight I'm going to be on the bike a lot. Because I would have lost sleep from the night before, was trying to accomplish way too much in that day. I'm exhausted. I know what I'm headed to.
That's right. Those legs are full on going to be on Tour de France. Then the other critical thing is your iron status. We know that iron deficiency can be associated with restless leg syndrome. So that's one of the things that out of the starting gate, we have a patient who comes in, we make sure we get their iron tested. There are some other things like magnesium, B12, some of the vitamins can also sometimes be associated, but so we'll kind of tag those on too. But iron deficiency is a big one. And why that's critical is that for some folks, if they're iron deficient and we replete them, that is the only known cure. We always want to look for that. So
how about alcohol and caffeine?
Great question. So alcohol can be associated, especially close to bedtime, can be associated with having more of your RLS. The reason we think that is because, alcohol, it's a sedative at first, but then it's metabolized so quickly you get rebound insomnia. Right. And that whole process of anything that disrupts your sleep is going to affect your RLS. Mm-hmm. So that's why alcohol close to bedtime, not such a good idea. Caffeine is mixed bag. Some things say it makes it worse. Some things say it doesn't matter. I typically tell folks, though, you know what? Know your body and caffeine and know when you probably need to cut that off in general. So we start there. We also make sure you don't have sleep apnea. Sleep apnea, there have been studies. Sleep apnea and folks with RLS, if you treat their sleep apnea, their RLS will also get better. So you need to screen for that. And then finally, there are medications that you can use if all else fails.
How about narcolepsy? What is that?
Narcolepsy is one of the more characterized of what we call central hypersomnias. So central just meaning from the brain, and hypersomnia, you're sleeping too much. Narcolepsy is in that categorization of sleep disorders where people are sleeping more than they like during the day, and this is despite getting adequate sleep opportunity. Narcoleptics will have other constellation of symptoms that go along with that. There are the narcoleptics who have what's called cataplexy, and those are individuals when they hear a funny joke, they're surprised, there's an emotion, emotionally, they're just caught by surprise, they'll actually lose muscle tone. They're still awake, but they'll actually lose muscle tone.
Wow.
So they'll have that. You'll have what we call sleep attacks. They'll actually lose track of time, so it's called automatic behaviors.
That's scary.
And then because what happens in narcolepsy is your REM sleep is inappropriately intruding on your day, and all of these symptoms is just products of REM, people also dream at inappropriate times. So they will quickly go into the dream state like in a nap. And it almost feels like a hallucination as they're going to sleep or waking up.
Yeah.
So that's what a narcoleptic will have. And they'll even feel like their brain is awake, but their body is paralyzed. That's also part of this unstable REM sleep. So that's kind of the constellation of symptoms you see with narcolepsy.
That sounds like a really damaging for quality of life.
Yes. As you can imagine, folks, by the time they may even get to see us, they've done things to sort of self-protect. So they usually try not to go to comedy shows. They don't try to see funny movies.
They figured out the triggers.
Exactly. So it's a shame that they've had to feel like they've had to deprive themselves of some of those kind of emotional experiences.
A lot of the people that are listening to this podcast today are moms. Can you give some advice regarding tweens and teens?
Yes.
Because we know that they kind of like to burn the midnight oil, right? They want to get in as much texting time as they can, listening to loud music as much as they can, being on, and yet they're having, we hope, appropriate growth spurts,
right,
which may be requiring more rest.
Yeah, absolutely.
What can we do to help our kids get the right rest so that we can set them on a path of sleep wellness?
Yes, and if I had all the answers to this, I'd be sipping Mai Tais on Tahiti. But I do, as a mom of teen and tweens myself, it's a challenge every day. But there are a few things that we should know that we can use at least as a foundation to work with. So we talked about 7 to 9 hours is what the average adult needs to function at their best. 9 to 10, even more. 9 to 10 is what the average teen and tween needs to function at their best.
Boy,
and we know that that's not happening.
No.
We have to see this again as, is this critical? Because not getting that amount of sleep has been associated with greater anxiety, depression, school performance, even car accidents. We have to think about it as a priority from that standpoint. The other thing is we're in a real live experiment, right, with electronics and social media. What we do know now is the kids who have a phone, social media in their room on average, they get 1 to 2 hours less sleep per night.
I'm not surprised.
So that could be the first start. It's very difficult because this has now become almost like their natural appendage. Those are the data you need to think about as to what interventions we can do. If that means that you just have a time limit, the data is there.
Click that switch off, and the parent needs to control that switch.
Yes, the data is there. The data is there that's impacting just merely having that phone in the room at night.
Yeah.
That's what's going on. It's hard. A lot of kids are doing a lot of activities. They've got homework late at night. But as much as possible, you have to think about where your child can have just even 15 to 20 minutes of decompression. Decompression, the same things that we need to do for ourselves. They need to do, plus they need 9 to 10 hours ideally to do it. But that's not going to happen certainly overnight, but even knowing that's the goal.
If you can ease into it, right? Yes. Maybe 15-minute increments to get to that point, that would be wonderful.
Exactly.
Yeah, absolutely. You are a wealth of information, which does not surprise me because I've known you for some time. I know that our audience today has very much valued learning about the various things that can happen when we're sleeping and when we're not sleeping well. And hopefully they will take some of these suggestions and apply it to their family and apply it to themselves. So thanks for joining us today.
It was a pleasure talking with you, Lily, today.
Thank you
for having me.
Sure.
Thank you for listening to A Woman's Journey podcast. Join me, Kelly Gear-Ripken, your host, Lily Shockney, and a variety of Johns Hopkins experts on the first Thursday of each month to learn about medical advances in women's health. A Woman's Journey is grateful for the unrestricted educational grants from Biosense Webster and Boston Scientific that support our podcast series, Insights That Matter. For more information about A Woman's Journey, visit our website, hopkinsmedicine.org/A Woman's Journey, and like us on Facebook and Twitter. Until next time, stay well.